have the pleasure of introducing Dr. Anu Ghuman. She's one of our, how do I say this, rising stars here in Providence Health. She is a trained colorectal surgeon. She does a lot of quality care improvement. She certainly has a huge dedication to surgical patients, and it's just been honestly one of the highlights of my last year and a half being able to work with her almost on a weekly basis on different patients. Of course, I give a friend the hardest talk, which is basically give an overview of IBD surgery. And although obviously we refer our patients to surgery to the colorectal team, I think often it's the IBD nurses along with the doctors that often first bring up the idea of surgery, and certainly sometimes we get involved in the post-operative care. And so I think you will find this talk of high value. And again, thank you so much, Dr. Ghuman. I know she's had a very, very busy week. We got her to do a Sunday afternoon with us with our patient forum, and it's a great pleasure that I'm introducing her.
Thank you, Dr. Liang, for that very generous introduction. Can you all see my screen?
Absolutely.
Okay, perfect. So my name's Anu, or Dr. Ghuman. I'm one of the new colorectal staff at St. Paul's Hospital. So thank you for inviting me to speak with you today about IBD surgery. Here, let me just see if I can go into presenter mode. So today we'll be talking about just basic GI anatomy. Then we'll talk about the various types of surgeries for inflammatory bowel disease. Next, we'll touch upon anastomoses. And I did throw in a little introduction to different types of stomas, because I think it's very important, especially for caregivers who are looking after these patients, to understand the various types of stomas that our patients with inflammatory bowel disease can have. And then we'll briefly touch about some post-operative complications. So first, a bit about anatomy. I'm sure you guys have seen many types of depictions of the GI tract, but just to quickly go over some of the points, when a patient eats, or any of us eat food, it gets transported through the esophagus into the stomach, where it gets digested and passed through the small intestine into the colon and out through the rectum and anus. The small bowel, as you may recall, has three different portions: the duodenum, the jejunum, and the ileum. And each of these areas is involved in extraction of nutrients and different types of minerals from our digested foods. And it's important to know, especially the ileum in inflammatory bowel disease, because they'll play an important role in the different types of surgeries and the most common sites of disease that we encounter. So next, this is an overview of the anatomy of the large intestine. So as the digested food moves through the GI tract, through the ileum, through into the cecum, through a ileocecal valve, and then out up the ascending colon, the transverse colon, descending colon, sigmoid colon. And the main job of the colon is to absorb water to allow us to make form stool. From the colon, it passes through the rectum, which is that last 10 to 15 centimeters of the GI tract, and its main role is to act as a storage house for the stool that is formed, so that we can evacuate through the rectum as we see appropriate. So here you'll see that the IVC, the vein, and the aorta are in the retroperitoneum, along with the kidneys, the adrenal glands on top, the pancreas, and then small portion of the small intestine, the spleen. You see here the colon, it's more intraperitoneal, along with the stomach. This is a depiction of the blood supply to the colon. And this is important because a lot of the different types of operations we do on the colon are dependent on the blood supply. So here you see the first branch, which is the superior mesenteric artery. And from the superior mesenteric artery that comes off the aorta, you have your ileocolic branch that supplies the ileum along with the cecum. You have the right colic branch, which supplies the right colon, as the name suggests. The middle colic, which supplies the middle portion of the colon. Further along the aorta, the most distal bifurcation, or the vessel that comes off the aorta, is the inferior mesenteric artery, and that supplies blood to the left colon through the left colic artery, the different sigmoidal branches to the sigmoid colon, and the superior rectal artery, which supplies blood to the top 1/3 portion of the rectum. Next, we'll talk about the different types of surgery for patients with inflammatory bowel disease. So this is just a quick overview of Crohn's versus ulcerative colitis. As you may be aware, Crohn's disease is a condition that affects the GI tract anywhere from the mouth to the anus. There can be skip lesions, so it doesn't have to affect the intestines or the bowel contiguously, but there can be areas that are affected, intervening with normal areas. And this condition is usually transmural, meaning it goes through the thickness of the entire wall of the GI tract. Perianal disease should raise the suspicion of Crohn's. Crohn's disease typically presents as either stricturing or fistulizing, and these patients can have bowel obstructions, abscesses, or perforation. As you're probably aware, Crohn's and ulcerative colitis are on a spectrum, and so ulcerative colitis, it only affects the mucosa of the colon and the rectum, and usually the anus is spared. It's a contiguous process, so it usually affects the bowel in a continuous pattern, and these patients usually present with bleeding, diarrhea, or toxic megacolon. Here are some of the features that differentiate ulcerative colitis from Crohn's disease. So basically similar things that we talked about in terms of the location. So ulcerative colitis in the colon and rectum, whereas Crohn's can affect anywhere in the GI tract. The rectum is usually involved in ulcerative colitis, and it can be spared in Crohn's. If you ever see any perianal disease, that usually should raise a suspicion of Crohn's. And then it just talks about different features that you may see on endoscopy as well, and on pathology. So indications for requiring urgent surgery in patients with ulcerative colitis is toxic megacolon. If patients present with fulminant disease that is not responding to medical therapy, they may present with perforation or significant bleeding. And the type of emergency surgery that we do for patients with ulcerative colitis is a total abdominal colectomy. And that's where we remove the entire colon and bring out an end ileostomy. When the patient is then over this initial surgery, they may have a staged procedure where we go and remove the rectum and either create an internal J pouch for them with or without a diverting loop ileostomy. It's important to know that this is usually a staged procedure because we know that if we're doing pelvic dissection, i.e. removing the rectum when they're quite sick, they have higher risk of complications. And so many studies have shown that when a patient comes in sick, we only remove the colon, but as I mentioned, ulcerative colitis can be cured by removing all the disease segment of the colon and the rectum. So it's important to have a discussion with the patient about removing the rectum at a later time when they're over their acute illness. So here's what a subtotal colectomy, or the other name for this is a total abdominal colectomy, looks like. It's where we remove all of the colon, so remove all of the cecum, the ascending colon, the transverse colon, the left colon, and the sigmoid. And we usually staple and divide it here, leaving the rectal stump in place in situ. And we bring out the distal ileum as an end ileostomy. Here is what a specimen may look like from the OR. And as I mentioned, once the patient has had all of the diseased colon removed, the second operation, if they choose to undergo it, is to remove the remaining rectum. We use the small intestine to fashion an internal pouch. So a J pouch is the most common type of pouch that we create. And then we usually divert them with a loop ileostomy to allow this pouch to heal. And then the patients will have a third operation, if they choose to close that loop ileostomy. There's some circumstances where patients may not want a J pouch or an internal pouch, and they may choose to keep their end ileostomy. And if that is the case, then we know that that rectal stump will need to be surveillanced because that rectal stump can still have ulcerative colitis. So it's still at risk of either having signs or symptoms of active disease, but also at increased risk of developing potential cancer. So that rectal stump needs to be assessed and possibly removed even if they don't want to have a J pouch. But here's a closer look at what a J pouch looks like. As you can tell, it's called a J pouch because of the way it looks. So we usually take two limbs of small intestine, that distal ileum. We fire a stapler in between them to make a common conduit, and then we staple it to the anal stump here at the bottom. And here you can see the stapler firing to create that common conduit. And then here another type of stapler, and we'll talk about these different types of anastomoses later in the talk, to connect the pouch down to the anus. There are other types of pouch, but again, like I mentioned, the most common type of pouch that we perform is the J pouch. But for various reasons, whether it's length or the patient's anatomy, they may have an S pouch or a W pouch. But again, these are much more rare. And this is depiction of a loop ileostomy. A loop ileostomy is where we bring out a knuckle of proximal small bowel, so proximal to that loop, and we create this loop ileostomy to allow our waste to be passed through the stoma rather than through the pouch in order to defunction the pouch to allow it to heal. And this loop ileostomy is usually in place for 3 to 6 months. We test the pouch, and if we're happy with how the pouch is healed, then the loop ileostomy will be closed in a third operation. So here, this depicts a total abdominal colectomy with an end ileostomy, and you can see here, this is what an end ileostomy looks like with one lumen. Here is where somebody has had a total abdominal colectomy with a J pouch creation and a loop ileostomy brought out from the proximal small bowel, and they'll have 2 lumens. This will be the functional efferent lumen where the stuff comes through into a bag, and this will be the distal lumen that is connected down to the pouch here. So as I mentioned, some patients may not want to have a J pouch, and there's various reasons to that. Some patients are completely happy with their ileostomy, and J pouch can have issues with pouchitis. Some patients that don't have good sphincter tone or of advanced age may not qualify for a pouch. Other patients may choose not to have to undergo multiple surgeries that are involved with a pouch. So they may want to have just a total proctocolectomy. That's where we remove the rectum, the anus, sew up the perineum, and they get to keep the end ileostomy that was initially created at their operation. And so this is because we can cure them of their ulcerative colitis, also reduce their risk of developing cancer in that remaining rectal stump that we spoke about. Next, we'll speak about the various surgeries for patients with Crohn's disease. The most common reason that patient with Crohn's disease may require surgery is failure of medical management. And this is seen in about 30 to 50% of the surgeries that we do. Not 30 to 50% of patients with Crohn's disease, but 30 to 50% of the surgeries we do for Crohn's disease are because of failure of medical management. About a quarter of the patients that we operate on, it's for obstruction. Emergency surgeries are performed in patients with Crohn's disease for perforation, abscess, bleeding, fistulas, or if they develop cancer. And cancer dysplasia is also another reason why we would operate in patients with ulcerative colitis as well. So a patient with Crohn's disease could present with a stricture, and the fibrostenotic type strictures are the ones that are more likely to require an OR. The treatment for strictures in Crohn's disease include a resection versus an endoscopic dilation or a strictureplasty. So these are the 3 types of options that we have to treat strictures in Crohn's disease. And there's a lot of different reasons why a patient may require a resection versus dilatation versus strictureplasty. And we don't need to go into the nuances of that, but it's important to know that there are various potential options for patients with a Crohn's stricture. Dilatation endoscopically, of course, it has to be able to be accessible by either a colonoscopy or an upper scope. Strictureplasties are usually reserved for patients that have multiple areas of strictures, and we're worried about removing too much small bowel because they would be at risk of developing short gut syndrome. But a resection is the most common procedure that we usually do for patients with Crohn's strictures. A patient may present to the hospital with an abscess, and that's when they've either perforated a small segment and their body was able to wall it off, but they have an abscess around that area of diseased bowel. And so usually when this happens, we try to treat it conservatively with a drain. So we ask our interventional radiology colleagues to see if they can drain it to control the sepsis. And once we're happy that some of the sepsis has resolved, or at least treated initially, then we can go to the operating room. And why we do this is because we want to limit the amount of bowel that we may have to resect. Of course, if a patient is septic and we can't control the infection with conservative measures, they will require an emergency operation. Patients with Crohn's disease may also present with fistulas. Internal, and by fistula, I mean it's an abnormal connection between two epithelialized surfaces. So these fistulas can be between two loops of small bowel. They can be between the small bowel and the colon, and those are what we call internal fistulas. And the internal fistulas that are asymptomatic may not require surgery. So if there's a fistula between a small segment of small bowel and maybe a small segment of small bowel is being bypassed, these patients may not actually have any symptoms from it. Therefore, we may not actually need to operate. But sometimes these patients can present with fistulas, most commonly from the terminal ileum to the sigmoid, in which case they're bypassing majority of their colon. So these patients usually present with diarrhea, potential weight loss, malnutrition, and so those ones we usually need to operate on. Another common fistula that we see is what's called an enterocutaneous fistula. So that's a fistula between the intestine and the skin, usually the abdominal wall. And these enterocutaneous fistulas may be treated with conservative management. If they're a low output fistula, these patients will be put on bowel rest with TPN in the hopes that if stuff is not passing through there, that fistula may have an opportunity to close on its own. But many of these fistulas may require eventual surgery if they're high output. So next we'll talk about the various types of surgeries. So the most common site for Crohn's disease is the terminal ileum, that distal portion of the small bowel before it enters the colon. And the most common operation we perform is an ileocolic resection. So this is a depiction of where there's a stricture or an obstruction. So the patient may require a resection where we have to go back to grossly normal disease proximally, divide the bowel there and divide the bowel just above the cecum and reconnect the small bowel to the ascending or the right colon. Another type of common operation we do with Crohn's disease is the small bowel resection. So this is for patients that have strictures that can cause a bowel obstruction, for patients that have fistulas, and we usually limit the resection that we have to do to a segment that is grossly diseased. So they may still have some endoscopic evidence of Crohn's disease, but we're hopeful that if we remove the gross disease, that the medications will have a chance to allow the other segment of the bowel to heal. The goal again is to preserve as much bowel as possible, because we know that Crohn's disease unfortunately cannot be cured with surgery. So these patients are at risk of having recurrent diseases, potentially requiring multiple operations throughout their life. And we worry that these patients can sometimes develop short gut syndrome. So it's really important to try to preserve as much bowel as possible during each of these surgeries that are required. Another type of common operation that we perform for patients with severe perianal Crohn's disease. So perianal Crohn's is where they have fistulas from the anus to the perianal skin. They can have recurrent abscesses and ongoing drainage. And if they don't respond to medical treatment, they may require what we call an Abdominoperineal Resection, an APR. This is where we remove the anus and the rectum. We close the perineum with a suture, and we bring out the end sigmoid colon as an permanent end colostomy. Patients that have Crohn's disease that is limited to their colon, but have the anus spared and they don't have any perianal Crohn's disease, may be a candidate for a total abdominal colectomy with an ileorectal anastomosis. So this is where we remove all of the colon and we connect the ileum to the top of the rectum. So you can imagine, as we talked about earlier, that the colon's main job is to absorb water. And so these patients no longer have the colon. When we do an ileorectal anastomosis, these patients usually have at least 5, if not up to 8 or 10 bowel movements a day, because they have very liquidy stool and the rectum can only hold so much stool before they have to empty it. Another operation that we can perform for patients that have disease limited to their colon, but also including the perianal region. So if they have perianal Crohn's and Crohn's colitis, meaning it's limited to just the colon, they can also be a candidate for what we call a total proctocolectomy with an end ileostomy. So that's where we remove the anus, the rectum, and all of the colon, and they have a permanent end ileostomy. Unfortunately, patients with Crohn's disease are typically not candidates for a internal pouch, such as the J pouch that we mentioned, because we know that they can develop fistulas from their pouch to their anus. So we have seen where patients are, as we mentioned, have indeterminate colitis potentially, because ulcerative colitis and Crohn's colitis are on the same spectrum. So if patients have indeterminate colitis, they may have a total abdominal colectomy with a pouch procedure, and many years or decades they can develop fistulas from the pouch to the perianal skin. So typically speaking, if we know up front that the patient has Crohn's disease, they're generally speaking not candidates for a pouch procedure. And so they may opt for a surgery such as this, where they're one and done and then have a permanent endstoma. There's various types of colonic resections that we do in Crohn's disease, and it depends on the site and the extent of disease. So in ulcerative colitis, we don't typically do segmental resections. We remove the entire colon because we know surgery can be curative. But in Crohn's disease, as I mentioned, there can be skip lesions, so areas of healthy bowel, and the goal in Crohn's disease is to preserve as much bowel as possible. There's various types of colonic resections that they can have depending on the site of disease. So we'll quickly go through some of those. So a patient may be a candidate for a right hemicolectomy. That's where we remove the right side of the bowel and we connect the ileum to the transverse colon. That's what a specimen would look like for that. We can do a segmental colectomy. So if only the transverse colon is involved, we can remove that segment of the bowel and reconnect the colon there. We can have a left hemicolectomy where we transect the bowel in the distal transverse colon and the sigmoid colon and reconnect the transverse colon to the sigmoid. They can have a sigmoid colectomy or an anterior resection where the disease is limited only to the sigmoid colon. And so we remove just the sigmoid and connect the colon to the top of the rectum. And if a patient presents with either an obstruction or they're malnourished or for whatever reason it's not safe to connect the bowel, they may end up with what we call a Hartmann's procedure. That's where we remove a segment of the diseased sigmoid colon, bring out the proximal healthier descending colon out as a temporary colostomy, staple and leave the rectum in place, and then come back as a second operation, take down the colostomy and connect it to the top of the rectum. And this is the same type of procedure that we usually perform in perforated diverticulitis. Next, we'll speak about anastomoses and how to reconnect all these different types of bowels that we have, all the different types of surgeries we have talked about earlier. So this is the most common type of anastomosis that we do. So a lot of the anastomoses that we perform are with staplers. And so this we'll talk about as a side-to-side anastomosis. So this is a linear cutting stapler that's depicted here. We staple and divide the proximal and the distal end of the diseased segment of the bowel, and we divide the mesentery in between. So this portion is then removed. We take our two limbs of the bowel, cut the corners, and then we pass a stapler down each limb. And this stapler has 2 rows of staples and a blade. So what it does is we pass the stapler through here, and the stapler will be fired, creating a common channel between these two limbs. So fire 2 rows of staples and a blade in between to create a common channel. And then that common enterotomy site where we pass the stapler through is stapled off. So at the end, we'll have a stapled side-to-side anastomosis, which essentially functions as an end-to-end. So stool is passed through here, around the bend, and out the other side. So it functions as an end-to-end, but it's created in a side-to-side fashion. Another common type of anastomosis that we do is an end-to-end anastomosis. And this stapler is usually to staple the bowel to the rectum. So here is the handle. This portion is passed through the anus into the rectal stump. And this anvil here is removed and sewn into the proximal end of the bowel. So here you see the anvil is placed into the proximal end of the colon and it's sutured in place. Here we pass the stapler through the anus up the rectal stump and we then deploy this spike. So this spike comes out through that stapled rectum. And then we engage this anvil to this spike and we close the stapler, bringing these two ends of the rectum and the colon in contact with one another. And this is a really cool stapler because it fires a row of circular staples to connect these two lumens together to create an end-to-end anastomosis. And that's what it looks like at the end. Another one that I didn't depict here is, of course, as I mentioned, this handle is only so long and it can only be passed up to the rectum. So if there is an anastomosis that needs to be made between two lumens of the colon further up, say in the transverse colon, then we can perform a hand-sewn end-to-end anastomosis where we sew these two lumens together by suturing them. Next, we'll briefly speak about the different types of stomas that our patients with inflammatory bowel disease might have. So what is a stoma or an ostomy? It's actually a surgical procedure where we remove a segment of the diseased bowel, so either the colon or the intestine, and we create an opening in the abdominal wall to allow elimination of stool. There are 3 different types of stomas. So there's an ileostomy. As the name suggests, it's made from the ileum, or the small bowel. There's a colostomy, which is made from the colon, the large intestine, or a urostomy, which is made for elimination of urine. These stomas can be permanent or temporary, as we have previously discussed. An ileostomy, as we mentioned, is made from the ileum, the small intestine, and it can be an end ileostomy. So after we remove the colon, and so either during a total abdominal colectomy or a total proctocolectomy, so that will be an end ileostomy. And those ones are usually permanent, but sometimes temporary, as we've already mentioned. A loop ileostomy is a diversion to bypass either a segment of diseased bowel or to bypass the pouch, as we mentioned earlier, to allow it to heal. And those are usually temporary. Ileostomies in general are of a smaller diameter. The average diameter of our small intestine is 3 centimeters, usually located in the right lower quadrant, but it can be located anywhere along the abdominal wall. And the output from an ileostomy is usually much thinner. So these are the patients that are high risk of having high output and potential dehydration because they no longer have the colon to absorb the water. Colostomy, as we mentioned, is made from the large intestine, the colon, and it too can either be an end or a loop. An end colostomy is such as the Hartmann's procedure that we mentioned, or it can be a loop colostomy to divert patients that have severe perianal disease. And if we want a trial of the biologics without ongoing sepsis, we may end up doing a diverting loop colostomy, which can be temporary to allow the medication to work to allow the fistulas to potentially heal, or it can be a permanent end colostomy, such as after an abdominal perineal resection, where we remove the anus of the rectum. And the output from a colostomy is usually soft form stool, like we would if our entire GI tract was intact. Here, there's just a depiction of the different types colostomies you can see, and you can see that they can be positioned at different parts of the abdominal wall, depending on which portion of the colon is brought out as a colostomy. So next we'll talk about complications. So there are early and late postoperative complications for patients that undergo surgery for inflammatory bowel disease. Early post-op complications are bleeding, anastomotic leaks, ileus, wound infections, and then stoma issues. So as I mentioned, patients may have high stoma outputs. They could have a stoma retraction. They can have skin separation from the stoma, and they can have peristomal skin issues requiring complex pouching in order to protect the skin around the stoma. Patients can have late postoperative complications, so that can be a recurrence of their Crohn's disease. So they can have fistulas or strictures. They can have anastomotic strictures, and this is not just for patients with inflammatory bowel disease, but any type of anastomosis or connection we make in the bowel is at risk of having a stricture. Patients that have had any type of abdominal surgery are always at risk of adhesions and having bowel obstructions. As I mentioned, with Crohn's disease, we worry about potential short gut syndrome. So if we removed a significant portion of their small intestine and their colon, these patients can have significant implications for nutrition and short gut syndrome. Again, patients can have stoma issues in the long term, such as prolapse, retraction. They can have a hernia around the stoma. They can have high output causing dehydration. And again, these patients, some patients with J pouches or any type of pouch can have pouch issues such as pouchitis. They can have pouch obstruction, because where we make that connection between the pouch and the anus can also stricture down. And of course, any abdominal surgery, patients are at risk of having incisional hernias. So that's the end of my talk. So thank you for allowing me to present, and I'm open to taking your guys' questions.
Hi, Dr. Ghuman. I have a question.
Yeah.
It's Katie, the dietitian at the IBD Center. This is a question I don't know if it's a silly question, but this is something I've wondered a lot, and I've had a few patients ask. For patients who have a J pouch, they're, as you mentioned, their large intestines removed, which, as we know, has a lot of their gut microbiota there. And so how does that look for patients who have a J pouch? Is that the microbiota recolonized, or do we know much about what that looks like in a J pouch?
That's great that you ask. I am doing some microbiome studies with patients with rectal cancer, but this is a very hot topic, as you mentioned, about the microbiome and repopulation. One of my former colleagues is really big on the microbiome, and he is looking at exactly that. Even patients that have loop ileostomies, and when we close the loop ileostomies, what does their gut microbiota look like? Of course, these patients that have had J pouches lose the colon, which is the main reservoir of the majority of the gut microbiota that we have, but that's not to say that the small intestine can also not repopulate. What that gut microbiota looks like, I don't know the specifics, and I'm not sure that we've fully uncovered that, but I definitely know that there are a lot of studies going on looking at that. So what implications that might have for function is a big question that's being asked and being investigated. But at the current time, I don't know what we fully understand about that.
Okay, yeah, I thought that might be the case. Thank you.
I have a question. Thank you for a very informative talk. It's always helpful to have the images to go along with the fancy words, so it kind of just helps me understand things a lot better. But the question I have is for our young patients who have required a colectomy when they are of childbearing age. I was under the impression that when they do get a pouch, that does impact their fertility. And so when you do counsel the patients, like I don't know, like how much does that impact them, and do you counsel against it, or, you know, yeah, just how does that discussion go?
So that's a very important question and a very good question. I definitely have that discussion with all my patients of childbearing age, because we do know that any pelvic dissection in a woman can affect fertility. We know that there are, one of the studies I was involved with when I was a fellow was looking at exactly that, pelvic dissection, and we were doing a randomized controlled trial with either do you pexy up the ovaries to keep them out of the pelvis and to keep them from scarring during this operation. We were trialing this material called Separfilm that's supposed to prevent adhesions, and then thirdly, just leaving them. And they were actually testing to see the patency of the fallopian tubes afterwards. So it was a really neat study, because there's some surgeons that will always pexy the ovaries. There's others that would leave the fallopian tubes alone. My approach to these patients is that I always have a frank discussion with them up front. If we can avoid pelvic dissection, then I usually tell them that we should avoid it until they're done with their childbearing ages, if it's possible. Of course, if they're having medically refractory disease that's affecting the rectum and they're having significant issues from that and we can't get that controlled, then we may need to do the completion proctectomy during those childbearing years. But majority of the patients that I've been involved with thus far in my career, I've usually counseled them against having any pelvic dissection if they're thinking about fertility down the line. So with Crohn's disease, we can, like I said, do that ileorectal anastomosis if they don't have any perianal disease. And that's what I generally do for my patients that are of childbearing age. And we know that if they develop a recurrence or they develop issues with the rectum, then we can always go back and do the completion proctectomy later down the line. With patients with ulcerative colitis, we typically do it as a staged procedure anyways. So we'll do the total abdominal colectomy. And if they are happy with how things have progressed in terms of if they're not having too much ongoing issues from their active proctitis, or if we can treat the proctitis with topical treatments, then we'll usually advocate for that. And then years down the line, after they're done having their kids, we can talk about doing the completion proctectomy and doing the pelvic pouch. Some patients are quite adamant that they don't want their stoma, and so they'd rather have all their surgeries up front, which is a reasonable option as well, because we know that patients who have had pelvic dissection still can get pregnant and can carry a child safely, but they may need some assistance with fertility issues. So I just have those frank discussions up front, and I allow the patient to be, of course, involved in that decision making process. And as long as they're aware of all the risks and benefits of each approach, we usually just have a joint discussion about that. Thank you.